The pleasure to welcome you and to start with this plenary session that is devoted to political economy of global health. I'm an economist by training at the origin, so of course this is my daily work. I underline two words here: political. So it's politics, it's policy making, it's law making, and economy that reminds us economics, but also economic constraints or scarce resources or used in the more efficient and hopefully equal way to give services. We are in a summer school that deals quite a lot with these issues, with this dimension of political economy, of health services. But I think that tonight it's okay, it's a good occasion to give a look closely to that issue with a guest, with Pooja Yerramilli. She works at the World Bank as a health specialist, but she also works as a attending physician at the George Washington University, so it's US. She has done something else in the past. And I've learned from her CV that she was, when she was even younger, educated in political sciences, and this is very interesting for all of us. So before leaving the floor to her, to her presentation, I mean, I'm quite interested, but I think that this is a key topic, and I just give you three reasons why I feel it's a key topic in general. The first, it's very simple to say. We have seen a lot of politics, political economy, political crazy dynamics during the pandemic. That was really a huge example on how policy making or political economy can help to solve problems or can have problems. That experience is also underlined the second element of political economy when we are dealing with global health, or in general, I would say public health. And this is the dimension of the international action. If we think about politics and the political system, it's mainly national-based system. And we all know how difficult it is to set up rules that are, let's say, applied in an international context. I don't have to say anything about wars or about fragile states, but we all understand very, very well that in a globalized world, because we move, we travel, we eat something that was produced elsewhere, we need an international response. And it is incredibly difficult to set rules in this international setting. The very last word is about some of you. We are here in Switzerland. This is an exception. Here, politics is very long. It takes years to make new laws. But once the law has been set, discussed in the parliament, gets passed in the parliament, and also eventually in a popular election, votation, it lasts for years. I am Italian. This is not at all the same. So political economy in Italy, it's much more difficult than here in Switzerland. And I don't want to say anything about your countries of origin, but I wanted to say, please keep the objectives in mind and fight for keeping the objective of your mind, because to work in political contexts where the states are so fragile, when every election can change dramatically the framework when a coup d'etat, so a revolution or a military revolution, can destroy years and years of work. This is something terrible, but we have to do with it in any case. So thank you for keeping, let's say, straight your objectives, and I'm glad to leave the floor to Pooja Yerramilli. Thank you very much, Pooja, for being here with us, even if online.
Thank you so much for having me. And I realize this is a really large topic, and we don't have, a ton of time. And so we'll take certain slices of it, and then I would love to kind of see where the discussion goes. But before we begin, I wanted to take a minute to just compliment the very generous introduction you already provided with some basic information about myself. And I think it's always sort of important to center kind of our experiences and how it's shaped our views. And so my pronouns are she, her. I'm Indian American. So my parents emigrated from India in the 1980s to the United States. And I grew up in the Northeast of the US, making frequent and extended trips to India to visit family, which over time evolved into some of my early experiences in volunteering, global health research, et cetera. And then we kind of already talked about how it sort of dabbled across different sectors, but importantly, I think just in terms of my work experience, is that I've worked as a physician, I've worked with NGOs and civil society organizations domestically and internationally, as well as with multilateral organizations. And all of this is to say that, I include the standard disclaimer that views are my own, but with the asterisk that my views are very much shaped by many others who I've encountered along this kind of circuitous path. And I'm anticipating that this community, this Summer School of Public Health, will become one of those additional interactions and experiences and communities from which I can continue to learn and shape my perspectives. And I hope you feel the same way. So with that, just to kind of outline the broad structure of this presentation, the first section will talk about the context. So why are we talking about the political economy? The second, we'll talk about frameworks and approaches. So how can we apply political economy analyses to enhance our effectiveness in public health? And then the third sort of large section is discussion. I really want to hear from you about your experiences and reactions on this large topic and the slice of it that we're going to look at today. So starting with the context, why are we talking about political economy? And I think we've already heard some of this in our introduction, but I wanted to start with a number, 1,137,057. And unfortunately, I can't see the chat as I'm presenting this, but perhaps to yourselves, you can guess what this number represents. This is the most recent estimate of the cumulative COVID-19 deaths in the United States, which is my home country. A second number I'll throw up there, 82%. This is the United States average JEE capacity score, or Joint External Evaluation Capacity Score. For those of you who aren't familiar, it's a measure of technical capacities for pandemic prevention, preparedness, and response. And this number suggests that we are among the most prepared countries in the world for pandemics. So why did we fare so poorly? As many of you are intimately familiar, this incoherence played out around the world, right? So pandemic preparedness metrics, whether you look at JEE, Global Health Security Index, a variety of other measures, did not sufficiently predict the effectiveness of pandemic response. So what were we missing? Studies have suggested that technical capacity is necessary, but not sufficient for pandemic preparedness. We've been overlooking some key factors. Policy choices, as was alluded to earlier, that were made may have ultimately been not based in evidence or been based in evidence depending on who is in power. But even the policies that were evidence-based were undermined by complex and historically overlooked issues like trust across communities, health systems, institutions, and governments. And I think these experiences are really important to ground this conversation in because they magnify the reality that policy and programmatic choices and their successful design and implementation are ultimately steeped in longstanding political and economic dynamics. So if we take the US, again, as a quick example, we know that trends on deaths could have been significantly different if social distancing, which was an evidence-based policy, had been implemented 1 or 2 weeks earlier. That's a policy choice, right? If we look at this statistic, which is over 200,000 deaths that occurred between June 2021 and April 2022, that were vaccine preventable, this represented 60% of all COVID-19 related deaths in that period. We know that low health literacy, distrust, divisions across society limited both access and demand for vaccines in some communities across the US. And again, these factors are driven by historical and current political economy. And so to make sure we're all talking about the same thing, I think we tend to kind of wave around this large term political economy without really defining it. And there are many different definitions we can take, but the one that I'll focus on or kind of direct us to today is sort of as the name suggests, the interaction of political and economic processes within a society, the distribution of power and wealth between different groups and individuals, and the processes that create, sustain, and transform these relationships over time. So how does the political economy interact with health? So essentially, and again, this is a very broad definition, the political economy is a core determinant of how distributions of power and resources impact health by affecting the conditions in which people live and work. It determines the structural, social, and commercial determinants of health. And the political economy of health is driven by complex relationships between institutions and stakeholders from community to global levels. Ultimately, how these different spheres from community to global level interact and intersect determines the level of health equity within and across countries. So that's just laying the foundation to make sure we're all on the same page of what we're talking about when we say political economy. Now, I wanted to take a quick example that's actually within the health sector. So we've just laid out this broad definition, sort of looking at both within the health sector and outside of it. But let's look at this idea of saying we need to invest more in primary healthcare, right? This is a common sort of call to action within global health. If we take the view from the global political economy lens, how we approach this call to action really shifts. Because what we know is that chronically, the net financial outflows from quote unquote developing countries is about 24 times the global aid flowing in the opposite direction from quote unquote developed countries. This outflow is from debt with interest, profit repatriation from foreign direct investment, and capital flight. And this statistic is cited in Jason Hickel's book, The Divide, which I encourage you all to read. And it kind of frames this overarching issue of how we frame the amount of aid that is flowing to developing countries in the context of the larger political and economic forces. This quantified outflow, though, does not include the cost that countries can face from trade's impacts on human health and productivity. So, for example, the tobacco industry's impacts on rising cancer rates, or, as was a hot topic during the pandemic, inequitable access to vaccines, medicines, and technology, which ultimately result in avoidable morbidity and mortality, and thus have significant economic impacts. The structural barriers to mobilizing the needed domestic spending for primary healthcare are glaring. So we have global economic shocks, which have constrained government health budgets. And we've had actually a recent World Bank study that projected that total government spending over the next 4 to 5 years will remain lower than pre-pandemic levels in 41 countries, and only weekly increase in 69. And this will significantly limit health budgets. We also know in this context, this sort of chronic outflow context, that over the last 2 decades or so, we've had a proliferation of development partners, whether from government, so that's that first arrow of the $1 from developed to developing countries, or in the form of NGOs, private sector, academia, etc. And this proliferation of partners with their own agendas, while is promising and showing an accelerated interest in aid and development and global health, can actually challenge country ownership, right? Because it can lead to major inefficiencies, high government transaction costs, and health systems fragmentations when we're dealing with so many partners with their own agendas. And so all of this is to say that, I think this representation is important because it shows the complexity in which our quote unquote calls to action, in this case for primary healthcare, which is very much nested in the health sector itself, are embedded. It's a global political economy that inherently economically disadvantages quote unquote developing countries and incentivizes reliance on different partners whose programs don't necessarily integrate and can thereby undermine strong PHC systems. But even if we look at the national level, there too might be a temptation to fragment or verticalize agendas as opposed to investing in integrated primary healthcare systems. Investments in primary healthcare systems may take a while to demonstrate results since the focus is often on disease prevention. But vertical disease-focused programs or hospital-level interventions can have more highly visible and clear results in the short term. For example, the number of patients cured in a high-profile manner. The timeline of these kinds of vertical or hospital-oriented results are often better aligned to election cycles than those offered by PHC investments. And, I'm putting this all out there because, again, like I was saying, I think this context is really important anytime we're putting forth a value proposition or a particular solution that we're trying to advocate for. But that being said, I think it can equally be very overwhelming to think of all these different dynamics at once. The temptation is to say that, we've provided technical guidance, but there's just a lack of political will to implement it. So what more can we do and stop the conversation there? Or we can be tempted to try to sidestep these political and economic forces altogether and try to implement our own technical solutions. But that sort of puts us in that bucket of, having the risk of further fragmenting systems. But it also threatens the success of our solutions. So for example, if we're looking at strengthening PHC, it can be tempting to intervene directly at the service delivery or community levels. The World Bank publication that I cited on this slide goes through this example. Let's say we want to improve trust and accountability between primary healthcare providers and communities. We might suggest interventions like community scorecards, by which communities can evaluate their experiences with providers. And this generally seems like a good idea, right? It can improve responsiveness, it can get us towards equity and quality of care. But if we're operating in a context that's dominated by, for example, patronage, or the appointment of providers or public officials is based, or a system by which the appointment of providers or public officials is based on party loyalty or relationships, it becomes less likely that providers' behaviors will be impacted by community scorecards. See, in these environments, providers are significantly more accountable to political leaders or public officials than they are to the communities they serve, unless there's a strong linkage between the community and their political leaders. So this is obviously an oversimplified scenario, but it illustrates the centrality of political economy when we're developing our solutions that we want to implement. And it demonstrates the risks of trying to sidestep the political economy. So if this is sort of, again, overwhelming global and national system is the one in which we're operating, does that mean that we need to solely focus on overhauling the entire political economy? And if we can't, then we can never achieve real progress in health? My perspective is sort of in the between. It's yes and no. I think everything needs to happen in concert. While we try to shift the larger systems, there are still very concrete ways that we can apply these political economy analyses to our work in public health to actually make our research programs and policies more effective and kind of avoid some of the failures that were illustrated by the example of these community scorecards. So some examples of questions we can ask and answer through political economy analysis. Of course, overarchingly is the question of how can we shift the political economy to improve health equity. But as we're kind of considering solutions from a pragmatic level, we can also ask how we can apply political economy analysis to assess the likelihood that our solutions are adopted, effective, and sustained. And there are a number of different frameworks and analyses that can be applied to answer these questions. Today, I'll walk through one framework that can help us assess the likelihood of adoption. And it's, again, a very basic sort of framework, and it may or may not resonate with you. And some of you may, already be well aware of this, but it can help us kind of think through what the next steps are in terms of our own actions and thinking through our own work. So for those of you who don't know, Kingdon's a renowned American political scientist, and he devised one of the most fundamental frameworks in political science and political economy of agenda setting. We tend to assume that logic governs choice, right? So if a policy is technically sound based on values like health outcomes, cost effectiveness, equity, other parameters, that policy should be adopted. That's a very sort of technocratic approach to agenda setting. Kingdon recognized that agenda setting is much more of a quote unquote garbage can of simultaneous processes that sometimes align to create a window of opportunity and sometimes do not. So he conceptualized three streams: problem, policy, and politics. What he suggests is that the coupling of these three streams creates a window of opportunity. So going through stream by stream, the problem stream becomes quote unquote ready for coupling with other streams when conditions become problems. So for example, if we take a condition like, a high burden of NCDs, from a policy perspective, this is simply just a condition, but it becomes a problem when one of the following can be articulated: that there are concerning indicators that illustrate trends like a significantly worsening burden of NCDs, or a really large magnitude of burden. When these indicators can show a significant difference between the observed and ideal state, or differences across comparator countries. The second sort of way it can shift, a condition can become a problem, is if there's a focusing event, such as disasters or crises like the COVID-19 pandemic, personal experiences like policymakers who may have a special connection to a specific problem, or there are symbols. And in the United States, we can take, for example, how George Floyd's murder became a symbol in America for racism and police brutality, and the linkages to health as well. The third way a condition can become a problem is when feedback for a current program is generated and reported. So we have information on current performance of policies or interventions, including failure to meet goals or unanticipated consequences. And so when ideally several of these things occur, we can really articulate a condition as a problem. The second stream, which is the policy stream, becomes quote unquote ready for coupling with the other streams when policy alternatives are generated and selected based on certain criteria. So this looks at technical feasibility, how implementable the solution is, how acceptable it is in terms of equity and efficiency, and how tailored it is to anticipated constraints such as budget constraints. The risk is that we have policy fragmentation. So we have a lot of cooks in the kitchen and no agreement. And what Kingdon suggests is that you have to undertake dialogue with others in this sort of policy arena to have a natural selection of policy proposals by discussing it with others in the community. And once you have that selection, not just the generation of policy alternatives, but the selection and prioritization of policy alternatives, this stream becomes ready for coupling. The third stream is the politics stream. And this becomes ready for coupling when stakeholder power and interests shift. This can be facilitated by several factors, such as changes in national mood, conducive election results, such as changes in administration, ideological or partisan distributions, and sort of the relative power of aligned stakeholders and interest groups. And importantly, in the context of global health, or national health with these larger global perspectives, is that this includes development and global health partners and their interests, including the ability to generate results for their respective priorities. It also includes sort of industry interests, as was outlined earlier in the presentation. And so again, the coupling of these three streams creates a window of opportunity for agenda setting. The coupling of two streams doesn't necessarily do so, right? And I think that's where a lot of frustration on behalf of advocates and others comes from. Because just because we, couple a problem with a policy doesn't mean we generate a window of opportunity if the political stream is not yet shifted. Similarly, if we're ready to couple a solution to politics, but we haven't really articulated a clear problem, then it's unlikely that will be prioritized when policymakers are considering a wide variety of different priority areas within their limited time and budget, et cetera. And so we really need these three to align. So how do we get them to align? Kingdon sort of conceptualizes this idea of a policy entrepreneur as critical actors in coupling the three streams. These are advocates who are consistently willing to invest their resources, whether time, money, reputation, et cetera, to promote a specific position. And they engage in advocacy, but they also engage in brokerage. So they negotiate and they make these critical couplings across the different streams: problem, policy, and politics. Importantly, they also understand the ingredients needed to create windows of opportunities and recognize when one can be opened. So some characteristics of very successful policy entrepreneurs are that they have some claim to a hearing, right? They have expertise, or they have an ability to speak for others because they come from a specific group, or they hold an authoritative decision-making position in one of the streams. They're known for their political connections or their negotiating skills, as I mentioned. But perhaps, again, as I alluded to, the two most important qualities is that they're persistent, so they keep marching along in this way, and that they're prepared. They are prepared with a problem articulation that is nimble and that's based and grounded in reality. And they're prepared with, a handful of selected policy proposals for when that kind of political stream and opportunity opens up. And so I'll quickly kind of go through a case study of primary healthcare being kind of one of the politically and economically troubling areas when we look at priority setting. I think as I mentioned before, from a technical standpoint, many of us can agree that PHC is technically sound. But for decades, it's sort of, in many countries, failed to get on the agenda. And so one case study that my colleagues actually put together alongside government counterparts and others is this case of primary healthcare reforms in Romania. And what they did was they applied this framework of Kingdon's multiple streams to analyze what were the ingredients that sort of came together to enable the signing of this program of reforms for primary healthcare in 2019 that was ratified by 2021. And so what they saw was that there were certain shifts across these three streams. Within the problem stream, starting in, a long time ago, decades ago, but really in 2007, there was a clear articulation that the NCD burden was significantly increasing. At the same time, there was a low prioritization of primary healthcare relative to other EU countries, and there was a really high hospital expenditure relative to, again, the EU average. There were also significant avoidable hospitalization for ambulatory sensitive conditions. And so this was some of the key evidence that they were starting to build as to why primary healthcare is important. In terms of the policy stream, and you can see this in this timeline at various points, many different policy alternatives were tested. Models of multidisciplinary teams for primary healthcare reaching into communities were designed and evaluated by different organizations, whether technical partners like WHO or others. And these were elevated and selected to the highest levels of government and the ministries of health, et cetera. And so over time, over the course of years, specific solutions to advance PHC were well prepared and selected. And then here's where things really started to change. The politics stream shifted following the 2016 election. The government and the president, which represented both the center-left coalition and the center-right, respectively, increased attention to PHC. There's also a period of relative political stability compared to prior years. The thing is, as all of these shifts across streams were slowly occurring over the course of a decade, you could imagine a scenario where PHC could have easily reverted from problem to condition, given the long lag time between its rearticulation at the start of this timeline and the 2016 election. But PHC was fortified as a problem by worsening trends and focusing events. For example, the context of macroeconomic pressures. Romania had the widest deficit to GDP ratio in the EU in 2019. And at the same time, Romania was nearing the end of its European Commission Partnership Agreement 2014 to 2020, which actually had identified priority issues for funding through EU grant mechanisms, and as one of them, explicitly referenced the imbalance between PHC and hospital-centric care in Romania. So this sort of problem rearticulation ultimately resonated with both the Ministry of Health and Ministry of Finance, who then were able to politically align to elevate PHC yet again and identify it as a mechanism by which they could improve efficiency of spending. So ultimately, the coupling of these three streams resulted in this set of reforms that I mentioned. And I think this case study demonstrates retrospectively how we can identify and capitalize on windows of opportunities that eventually open over time and the persistence required to get there. But most significantly, by ensuring that the problems and solutions are well articulated, are adapted to changing contexts, and are coupled by the time political momentum has built. So you can say to a policymaker, okay, you have a problem, I have a solution, and kind of go from there. It also highlights the many different contexts, institutions, and stakeholders that have to be considered in political economy analysis. Individuals who may or may not be able to participate in and influence election results, for example, the elected leaders and the public officials that they appoint, and in this case as well, external institutions like the European Commission's priorities, which also kind of reinforced agenda setting in this scenario. I think the reality, unfortunately, that many of you and we kind of grapple with as well is that unfortunately the coupling of these three streams is not easy and at times can seem unlikely to happen. So what can we do in these instances? And this is where I would love to hear from you and your experiences in your everyday work. From my perspective, in terms of the problem stream, there are critical questions we need to ask. Like, are there other ways to rearticulate this condition as a problem? And in my view, this is how we can develop targeted policy relevant research. Rather than just sort of conducting research for the sake of it, we can ask, why is this condition not being viewed as a problem? Is it because it's actually not the biggest problem that this country is facing? Is it actually that we don't have enough data? Or is it because we're not tying existing evidence that we already have to the current and evolving contexts of focusing events or critical feedback from programs that are already up and running? So for example, for primary healthcare, we saw the rearticulation of primary healthcare and its underutilization and underfunding in the problem stream through the use of existing evidence that we've built over decades, alongside new evidence on service disruption during COVID-19. And many have articulated it as a problem core to the pandemic preparedness agenda. Now, unfortunately, that it seems that the global community is sort of moving on in many ways from COVID-19, we are also seeing primary healthcare articulated as core to the climate agenda, which is increasingly taking center stage. And we can see that pivot, and on the one hand, you can question, okay, maybe we do need to do more advocacy and engagement to ensure that PPR, pandemic preparedness, prevention, preparedness, and response doesn't fall off the priority list. We can be opportunistic as well about ensuring that other agenda and entry points are taken into account in the work that we do. In terms of the policy stream, I think we can ask focusing questions like, Are the policy alternatives that we are selecting really the most likely to be effective in the current context? Or do we need to revise them in consideration of the politics stream? So when we consider all the critical institutional and stakeholder interests that may prevent a technically ideal solution from, an equity, quality, cost effectiveness standpoint from progressing, can we find a compromise solution that may align with these overarching interests? When we think about this kind of paradigm, at least I'm reminded of this, one of the advantages of quote unquote diagonal approaches that combine vertical disease programs with opportunistic horizontal or PHC system strengthening. So for example, if you're sort of implementing a tuberculosis program and you simultaneously use that as an opportunity to build out supply chains across the system, that can be seen as sort of a win-win. I think the answers to these questions are complex and depend on your role within the system. Are you a researcher? Are you an implementer? Are you in civil society? Do you work in one stream? Do you work across all three? And other political economy frameworks outside of this one that I've presented, Kingdom's three streams, can help us begin to answer some of these questions. But, in the interest of time, I'm going to essentially leave it there. I know I've packed a lot in and weaved many different things together here, but I'll just throw these take-home messages up here. I think what I'd love for everyone to take away, and I think again, it resonates with this audience anyway, is that health and the political economy are inextricable. Health is political. Political economy analysis can help us understand and target the broader systems in which we are operating, but it can also help us improve the likelihood that solutions that we are considering are adopted, effective, and ultimately sustained. And I think the big opportunities here is that we all can become or engage with policy entrepreneurs to advance agendas, so long as we're persistent and very strategic in how we engage across those three streams. So to move to discussion, I think there's still so much to learn on political economy. And so, as I was saying, I'd like to turn it over to the audience now with the following sort of questions in mind. There are inherent tensions between our high-level technical guidance coming out of this pandemic, for example, and the current political economy. And I mentioned some of these at the start of the presentation. We say all countries need to increase PPR spending, and yet many countries around the world are facing significant constraints to their government budgets, let alone their health budgets, right? We say integrate horizontal health systems, and yet we have a proliferation of global partners, each with their own agendas. And we have various kind of political economy incentives across local, national, and global levels that might counter this goal. We say reduce inequities within countries, but we don't really engage with the systems that actually produce those inequities to begin with. In a similar vein, we're saying, we need to do more with community engagement, particularly across communities that are the most marginalized. But in many instances, right, and actually all instances, these communities are marginalized because of political and economic incentives that keep them that way. And so how are we actually aiming to consider these different political and economic drivers when we're developing our solutions, when we're engaging with different stakeholders? One kind of, additional area that I'll throw out for consideration, because I think it's one that's been sort of a hot topic in global health, particularly in academic circles over the last couple of years, is sort of this recognition of there's a predominance of articles that are written by academics in the global north about the global south. So recognizing this, there has been a recent push to increase authorship from the countries or regions being studied. And some journals have even introduced this as a requirement. Now, I think we can apply Kingdom's three streams even to this, right? The problem is well articulated, that there's this inequity in authorship. But I think not all of the solutions consider the broader political economy of why we see these trends, right? And if we actually consider those different stakeholder incentives and institutional incentives in context, we see that academics, for example, are incentivized to first author papers in order to get promoted, gain access to more grants, et cetera. And if we don't change these basic incentive structures, is it likely that we actually will achieve equity in authorship? So that's just food for thought that, again, I realize is kind of taking us in a different direction and separate from what I presented here today, but just to illustrate that even when we think we're talking about something that's quite separate from these dimensions that I've presented, it's very much intertwined. And so I'd love to hear from you all sort of how you think through some of these challenges and how it affects your daily work, and perhaps your experiences in interfacing or even being policy entrepreneurs in your daily work. So there are, as I said, this is one of, this is probably the most basic framework that I presented here today. And there's several other political economy kind of analysis frameworks that have been tailored to different circumstances and different reasons that you're applying it. And one of them I'm trying to see, because I think I have included this in an annex slide. So let me see if I can pull this up very quickly. But one of them is called problem-based PEA. And I'm not sure how well you can see this. And again, it's not, I'm not here getting into specific indicators because it depends on what you're actually trying to implement. But this is more of a prospective approach. And so what this starts with is saying, okay, sort of in my presentation as well, right? Like, we are starting with this very large, complex problem of political economy and all of these drivers. And if we get our heads lost in that, it's not super likely that we're going to make progress unless, you know, you're at the highest level of negotiations or advocacy. And so in our daily work, what can we actually do that can improve the effectiveness of our programs prospectively? So we look at our problem and we say, okay, let's take the example of primary healthcare and say, we have the technical and economic analyses. We know that this is a feasible solution in this particular context. Why is it a problem that's not being taken up? And why is it not being taken up? And then what this encourages us to do prospectively is to do a political economy analysis that is focused on sort of three areas. And I kind of loosely alluded to these during my presentation, but the structural factors, so that's sort of the context, the macroeconomic context, kind of demographic context, all of these things that a country faces. The institutions, so that's formal and informal institutions, whether they're, you know, laws, regulatory agencies, government structures, or kind of the informal interplay of social norms and social norm setting across communities. And then stakeholder interests, constellations, and power, and how those all sort of interact. And again, we can get more detailed into this, but I think it would probably suffice to leave it at this kind of basic diagram for now. But there are very structured ways in which we can prospectively kind of take these into consideration and say, okay, so maybe this is why this technical solution is not being taken up or is not being implemented effectively. And if we can't find a way for it to be taken up, because again, maybe using Kingdon's streams or referencing them, the window of opportunity simply isn't there, then how do we find the solution that actually sort of delivers progress and will be able to be implemented? And so I sort of think about this even, let's say in the context of let's say surveillance, right? In the context of pandemic preparedness. If a country is not strengthening its surveillance networks or is not prioritizing surveillance networks, we can think about it through this political economy. This is completely hypothetical, but we can think about it in this political economy lens of saying, well, what are the incentives to do so? What are the institutions? What are the contexts, right? And they may have a variety of different priorities and problems that are more acute in nature that seem to be more visible to their populations in terms of population need and kind of policy processes as well. But also, if you think about the global political economy, what we saw is that some countries that did disclose that they had, variants of concern were then sort of punished by the global political economy. We closed borders, their economies suffered. And so what is the real incentive there then to disclose that there's an outbreak or disclose that there's a variant of interest for COVID-19? And so those are the kinds of dynamics that we have to really think about when we're talking about, okay, is there a reason that this country is or these particular stakeholders are not investing in these technical capacities that we keep pushing? And is there a way that we can either address that at a high level in terms of structural changes in the global architecture? Or is there a way that we can accommodate that through these kind of diagonal approaches that are more opportunistic and saying, okay, they may not be prioritizing PPR disease surveillance, but maybe they're prioritizing these kinds of capacities in a different verticalized program, and how can we build on that to be able to build the capacities that are required for PPR? So that's kind of a hypothetical example about how we can apply this kind of prospective problem-based PEA that encapsulates all of these different dynamics from global to national to local levels in terms of incentives and stakeholders and institutions and structures, to tailor our approaches and not just throw in the towel when we notice that our technical approaches either have poor uptake or are being poorly implemented.
Thank you again to our guests online, and thank you also to other people that have attended online the session. Arrivederci a domani.